Good afternoon, everybody. We are starting to let folks into the meeting. We will give it a few more minutes or minute or so. We do have a lot of content that we will want to go over. So we'll get started as quickly as possible at close to 12. So just give us a few minutes. Okay, so we're at the top of the hour. We still have people joining us, but we'll get started with some housekeeping items. We have put most of the folks to come in with no video and no audio. This is being taped and will be available on YouTube for folks to review if they missed the course or want to review it as part of preparing for the exam. We will open it up and encourage you to join us at the end via video and chat, see your peers. Nice to see folks in person, even if it's Zoom. And then there will be, Anthony's going to be monitoring the chat for us, and we'll review any of the questions that come up forward at that time. Again, this is being taped for YouTube, so if you've missed any of the series, we have 5 prior training sessions. Can't believe we're already up to 6. And we've got 3 more to go. Those will be available again on YouTube, so go out there and encourage you to take that. You also do need to make sure you're following along in the e-learning course that is on the HFMA website. So if you haven't done so already, please sign in there, register for CRCR, and then you'll see the course in your e-learning section that's right next to your profile on the right-hand side. So highly recommend you try to be doing the same concepts at the same time. Okay, so we'll get started if my computer decides to move. Last week, we went through the first 3 parts of the time of service financial care, and we'll be reviewing the final 4 units or sections of this unit today. So coding, we'll discuss the importance of HIM and its impact on the revenue cycle, how diagnosis and procedure codes are used to communicate the reason for treatment, and how other departments and stakeholders utilize that information as it pertains to the revenue cycle. So what is HIM? They're responsible for the management of all patient records, which reflect all of the care provided to the patient and a description of all clinical symptoms and diagnoses. They are the primary source for clinical data required for reimbursement by health plans and liability payers. So the medical record is reviewed for the patient's clinical information, and the information is coded into the medical record system. Claim information is then electronically passed to the patient accounting system to meet claim data requirements. HIM plays an important role in ensuring the accuracy of the codes documented on the claim. So the HIM department completes several important activities, including ensuring the security and completion of electronic and hard copy medical records, transcribing physician dictation, including history and physical, operative reports, and discharge summaries, analyze information necessary for decision support, performing chart analysis, and of course, reviewing the medical record, assigning diagnosis and procedure codes, and classifying data for reimbursement. Once all of the above has been completed, the account can be deemed final billed and then should then create a bill to submit to the payer or to the patient. They must monitor all required physician documentation to ensure that the volume of discharge not final billed, or DNFB, does not continue to rise. If accounts remain in DNFB for too long due to untimely documentation, completion of lack of coding staff, this can seriously impact cash. So what is an EHR system? And I have to share that every time I tried to type EHR, it took me about 10 times to not have it say her, if you've ever typed it into any type of documentation. So a EHR is a digital version of a patient's paper chart or medical records. EHRs are real-time, patient-centered records that make information available instantly and securely to authorized users. Most providers have moved to electronic records versus paper records. And a main driver of that was years ago, I believe it was during Katrina, where patients' medical records were not portable and available for treatment. So providers have really embraced it more due to those types of issues that can impact care. While an EHR does contain the medical and treatment history of patients, it is built to go beyond standard clinical data and can be inclusive of a broader view of a patient care. It can include things like immunization dates, allergies, radiology images, and laboratory and test results. So the EHR is the connection of the clinical documentation process to the coding and charge processes that support claim generation. So pretty key to making sure we get paid for what we do. So what's their role? Clinical documentation is the source of all diagnosis and procedure coding and the detail of the specificity of the documentation by physicians and staff, including clear documentation of all comorbidities related to the patient's episode of care. Failure to properly code the primary reason for treatment, along with all comorbidities like obesity, diabetes, can negatively impact reimbursement. There are two types of coding systems that are used to communicate the reason for and type of clinical services provided to the patient. So diagnosis codes are represented by the ICD-9-10 CM codes that characterize the medical condition that a patient is experiencing. Example, abdominal pain generalized is ICD-10 R1084. Many of you know that there was a huge transition from ICD-9 to ICD-10 a few years ago to make the diagnosis codes even more specific. And while ICD-10 coding is no laughing matter, the federal government, with their exceptional ability to over-document everything, has created a series of diagnosis codes that have me cracking up. One of my favorites is Hurt at the Opera, Y92253. So I guess if the fat lady gets cranky, she can't sing. The CPT codes, HCPCS codes, associated with a service, procedure, or drug may be listed for specific charge in the CDM, and it is deemed hard-coded. It is typically used for procedures like radiology and laboratory. Soft coding is typically related to surgeries where I have to wait to see the actual event that occurred, which can change, certainly based on the patient's condition. So I have to wait for that, and then typically surgery will be coded, soft coded by the HIM coder. So beyond HIM, a number of departments rely on the codes that are assigned. So reimbursement and budget personnel actively model coding and reimbursement changes, both positive and negative, that result from the coding and assignment of MSDRGs or CPT codes, HCPCS codes. Controls are typically put in place to guard against unintentional downcoding or upcoding, which are potential compliance issues. The enhanced data mining opportunities that result from the more detailed coding under the ICD-10 allows senior leadership to work with physicians to improve outcomes, embrace new reimbursement models, and drive significant areas of quality in the patient experience. And in patient access, diagnosis and procedure codes are used to validate medical necessity. They must be obtained prior to providing healthcare services to a patient and map correctly to the health plan requirements like ABNs, or notice of non-coverage for commercial payers, and prior authorization requirements to avoid downstream denials. And then typically the patient accounting system uses a number of claim edits to ensure that their claims meet all health plan requirements prior to submission. Failure to comply with these requirements will usually result in either a rejected claim or a denied claim. The correct coding initiatives for Medicare are an example of those types of edits. So hopefully key points you came away with is clearly the importance of HIM across both the revenue cycle and the importance to the overall provider, and the differences between the diagnosis codes and CPT codes, hard coding and soft coding. Okay, so polling question we've got here is, what is the responsibility of HIM? So we'll give everybody kind of a minute to review that and start seeing the responses. Okay, Diane, if we want to close that. Oh, great, guys. Wonderful. Yeah, HIM has custodial responsibility for records that include tracking records, temporary filing for incomplete records, and permanent filing for completed records. Number 2 refers to EHRs, which are real-time patient-centered records that make information available instantly and securely to authorized users. Number 3 refers to the procedure codes represented by ICD-9 and CPT HCPCS codes. And then number 4 refers to a medical record, which reflects the care and is the primary source for the clinical data. Okay, let's talk about the fund claim form requirements, edits, and the importance of EDI. Right? So most of us in revenue cycle are familiar with UBO 4 1500s. Claim processing obviously includes all activities required to send a request for payments to a third-party plan for payment of benefits. The healthcare industry has developed standard claim forms that must be used for claim processing. The standard hospital claim form is a UBO 4, and then the standard professional claim form is the CMS 1500. Both do have electronic companions to that as well. The UBO 4 claim form contains 81 form locators and is usually used for submitting claims by institutional providers, hospitals, hospice, rural health clinics, skilled nursing facilities. The CMS 1500 claim form contains 33 form locators and is used by non-institutional providers, physicians, allied health professionals, certified registered nurse anesthesias, home health agencies, medical equipment suppliers, etc., to submit claims. Both the UBO 4 and CVS 1500 have been translated into electronic forms. EDI is the technology used for translating, standardizing, and sending electronic transactions electronically. Still no standardization, to my opinion, but the electronic version of the UBO 4 is called the 837I, or institutional, and the electronic version of the CMS 1500 is called the 837P, or professional. Using the standardized EDI format, both hospital and professional claims can be sent electronically and will include all of the same data elements as the paper UBO 4 or 1500. The electronic data set also includes more information that is represented on the paper form and is organized into groups called loops and segments. The benefits of electronic claim submissions are as follows. The submission, receipt, and processing the claim is automated, thereby eliminating mail time and reducing data entry time at the payer. The system editing function reduces the time spent when a claim is rejected, returned, and resubmitted. Providers can electronically monitor the receipt of claims by payers, eliminating delays caused by file transmission failures. Use of solicited 276, 277, and automated claim monitoring can eliminate lost claims and unproductive staff touches. Online claim adjudication can be performed with the provider receiving the adjudication result in real time. It doesn't happen too often, but it can. This enables the provider to accurately collect patient liabilities at the time of service based on the actual adjudicated information. Typically, the only place I really see that, guys, is in pharmacy. Not too much in the provider space yet. Real-time adjudication has not really got to the level that we'd like. And then finally, payment turnaround time is going to be faster versus submitting it paper and then getting a paper EOB. So promote implementation. The current version is the 5010, and to promote the implementation of electronic transactions and achieve cost reduction and efficiency improvement by creating more uniformity in the implementation of standard transaction. CMS created the CIQH, or the Council for Affordable Quality Healthcare. It was named by the Secretary of HHS as the authoring entity of healthcare operating rules. 130 organizations, providers, health plans, vendors, government agencies, and standard-setting bodies. Their goal is to ensure that detailed real-time response becomes the standard for claims-related healthcare to reduce administrative costs. And there is more work to be done to ensure consistent adoption and application, as there really is. We've not normalized and standardized in the industry across the ANSI transactional set yet. So clean claim, pretty important in processing and working through exception-based processing. A clean claim is defined as a claim that is sent to a payer, either electronically or on paper, that has no defect, impropriety, or particular circumstance requiring special treatment that prevents prompt payment. Providers should attempt to receive the highest clean claim rate, best practice being in the 95 to 99% of all claims required no staff touches, by putting robust edits in both their HIS system and their clearinghouse, and automating as much as possible of the rules and the edits. Claim edits are rules developed to verify the accuracy and completeness of claims based on each health plan's policies. Data sources for these are Medicare, Medicaid bulletins, manuals, individual health plan manual and contracts, and other documents routinely provided by health plans. The claim editing process lets providers identify and resolve claim issues to ensure clean claim submission, resulting in prompt payment, reduced AR days, increased cash flow, and reduced staff time to work claim. Prompt payment can be defined by payer contract or by state or government rules. A summary of the source of data is provided on the next screen to highlight the important role patient access is in clean processing. So when we look at, and why it's so important that particularly we invest in our patient access staff and the training that we provide that staff, 40% of the source of the data comes from patient access. 20% is going to come from HIM. 20% is coming from the billing system or system generated. 11% is coming into the service or ancillary department, and 9 is not used at this time. The CMS source of data, 53% comes from patient access, 14 from service department, 7% from the health information management, and then 26 from the billing office or system generated. So again, the key and the importance of trying to get the HIS system to be built right, to put in robust edits in your clearinghouse and get those claims either automatically corrected or stop it and edit it before it gets to the payer is certainly key to getting paid faster. So UB04 codes to know. There are 4 codes sets that provide health plans with additional information as they review the claim for payment. So condition codes are used by the provider to describe conditions or events that apply to the period being billed on the claim. For example, if it's an employee-related incident or injury, then code 02 should be listed. Occurrence codes can provide additional information pertaining to the period being billed in a claim. Again, if employee-related, occurrence code 04 with the specific date of the accident would be listed. So just as the name implies, an occurrence span code would be used for an event that spans a period of time. If a portion of a patient's inpatient stay was considered non-covered due to the level of care, a span code of 74 would be entered with the specific to and from dates. And value codes and dollar amounts represent data of a monetary nature. A common code is 01, which denotes the most common semi-private room rate in a hospital. So, we need to understand the basic claim requirements, making sure that they're clean, how we can use claim edits to ensure we get prompt payment. We're complying with all the necessary billing rules specific to the health plan types. Okay. So polling question, what are claim edits? Y'all a minute there. I can take a water break. Okay, we'll close that poll down and see what our results are. Good job, guys. Yep, number 1. So data sources for those claim edit rules, the Medicare and Medicaid bulletins, and other documents that let providers identify and resolve claim issues prior to submission to ensure clean claim submission. So here we go. All right, moving on, basic billing rules. We're going to basically talk through the basic billing rules for major health plans, basic billing rules and payment methodologies for specific providers like rural health clinics, hospice, skilled nursing units, ambulance, hospital billing, and clinics. And we're going to identify the purpose and billing components of what I'm sure everybody has heard recently, telehealth service billing, which has certainly had a huge surge in usage in the last couple of months. So as there are unique billing requirements based on different third-party and provider type rules, and in addition, some health plans may demand additional information before paying a claim, such as ED reports, history and physical, therapy notes, operative reports, or discharge summaries. Luckily, many commercial providers are starting to embrace electronic attachments, so claims don't need to be billed to paper and then mailed, resulting in increased processing time. The good news is there's some commonality in the requirements. A day begins at midnight, ends 24 hours later. The day of death, the day of discharge, or a leave of absence, if they have to go to another provider, are not counted as days. If admission and discharge or death occurs on the same day, that day is counted as one inpatient day if they happen on the same exact day. Providers typically submit a claim for an inpatient or outpatient episode of care, or a series of recurring claims for things like therapy. And so typically it's one claim. In certain circumstances, the provider may elect to submit an interim bill, typically used for extended inpatient stays, and it can usually submit every 30 days. Other payers also require things like you need to submit your bill for the end of year if patient's still in house on 12/31, and then start a new interim bill on 1/1. Timely filing for Medicare is within 1 calendar year of the date of service or discharge. Claims received by day 366 or beyond will be denied. Health plans will establish their own timely filing criteria and are generally noted in the contract and are typically much less than a year. Sometimes seeing claims must be submitted within 90 days, 120 days. So understanding what those timely filing rules are, not just timely filing for claims, timely filing for appeals and denials is important for providers to maintain. And we're going to expand on provider type billing rules on the next few pages. So UBO 4837 is the standard form for rural health clinics. Services are rolled up into revenue codes like 520 and 522. They're not itemized. Each state's Medicaid plan defines how it will pay for the services provided by an RHC. Therefore, Medicaid billing for RHC is often a very unique and complex story. So if you are managing an RHC, it is very important to contact the state Medicaid office and obtain basic information on its billing requirements for RHC. But across the board, Medicaid is typically our biggest pain when it comes to billing rules across the board and getting paid. I think we all know that. So hospice services, these are again generally for terminally ill patients and are provided by an organization or agency that is primarily involved in providing care to terminally ill patients. Covered hospice services are nursing, therapies, medical social services, physicians, counseling, DME supplies, home health, short-term inpatient care. There are 2 statutory exclusions from coverage: services deemed not reasonable or necessary, and services that are considered custodial care are not covered. It cannot involve the limitation of liability under COPB assignment. So if it's payable under state or federal workers' compensation, it's not certified to be terminally ill, or they already received 200 days of hospice care, then they will not get reimbursed for hospice care, okay? The hospice rate structure, there are 4 rate structures that we currently get done today. And that is their prospective payments and respective payments. And we'll go into retrospective payments that we'll walk through in a little bit more detail. Okay. So you have 4 levels of hospice care, and routine home care is paid per day, regardless of the volume or intensity of service, and is also paid when the patient is receiving hospital care for a condition unrelated to the terminal care. The continuous home care rate is divided by 24 hours to obtain the hourly rate. Payment for respite care may be made for a maximum of 5 days at a time, including the date of admission, but not including the date of discharge. This is payment to hospitalize the patient for a short period of time to give the caregiver respite when treating the patient at home. Day 6 and beyond are paid at the routine home care rate. And then inpatient is paid on the various level of outpatient care. Overall payments made to the hospice are subject to a cap amount calculated by the MAC. Any payments in excess of the cap must be refunded. Payments to a hospice provider for inpatient care are subject to a limitation on the number of days of inpatient care furnished to Medicare patients. So if the MAC determines the inpatient rate should not be paid, the hospice provider will be paid at the home care rate for those days. So coverage for extended care, skilled nursing facility, is a basic part of Medicare Part A. To qualify for coverage, the patient must have received medical necessary inpatient hospital care with a stay of at least 3 consecutive days in one or more hospitals. They must be needed for a condition that the patient was treated for during the patient's qualifying hospital stay. Care in a SNF is covered if all of the following 4 factors are met. Requires skilled nursing services or skilled rehab services. Requires skilled services on a daily basis. Daily skilled services can only be provided on an inpatient basis, not outpatient, and that ancillary services are available if needed on an emergency basis. Covered services include room and board, therapies, medical social services, drugs, biologicals, and DME. A patient is eligible for 100 days of care in a benefit period. As long as a patient is entitled to Part A, there is no limit to the number of benefit periods they may have. A benefit period is also synonymous with the spell of illness. Payment under Part B for clinical diagnostic tests can only be made to the entity that performed that test. For a SNF to furnish clinical lab tests and be covered, it must have a CLIA or Clinical Improvement Act certification. A SNF is permitted to bill every 30 days, but obviously it must be in sequence, which makes sense. And then if bills have been submitted, but no payment or reimbursement is intended, we still have to have no pay bills because those are necessary to maintain the beneficiary's utilization levels. Ambulance billing. Ambulance services are billed directly to the health plan for bringing the patient to the hospital for admission and a discharge to home or another facility. When inpatients require a particular diagnostic or service during their stay, and the hospital lacks that particular service, then they are responsible for the ambulance services. Both the ambulance charges and the services at another facility are billed on the inpatient stay to the health plan. To make sure that the ambulance supplier doesn't charge the health plan directly, claims are edited by the health plan to screen for ambulance charges that are to be bundled into the hospital payment. They can be paid under 4 methods: an all-inclusive base rate, a base rate with separate charge for mileage, a base rate to include mileage but charge separately for supplies, and then a base rate with separate charges for supplies and mileage. It includes oxygen, drugs, extra attendance, and EKG testing, but only if medically necessary. So while hospital-based physicians may maintain private practices outside the hospital, at the hospital they are responsible for providing critical services to admitted patients. As many of you know, many providers are moving to hospitalists and intensivists that actually manage the critical care versus the attending or the PCP coming to the hospital to care for their patients. These include ER docs, anesthesiologists, radiologists, pathologists, and like I said, hospitalists and internists, intensivists, sorry. Most will bill the patients directly, and billing is done on the 1500 or the 837P, and must include the code for the hospital as the place of service to be reimbursed appropriately. Even if the physician is contracted with the hospital, they may not be contracted with the patient's health plans. Patients may get balance billed for a percentage not paid by the health plan, and that is typically referred to as surprise billing, as you may have heard often in the news lately. So we have certainly seen a surge in telehealth and telemedicine this year, and I think that will continue regardless. It is considered a very cost-effective alternative to the more traditional face-to-face. It permits two-way, real-time, interactive communication between the provider and the patient. It includes a variety of applications and services, including two-way video, email, and smartphones. Medicare used to pay for a limited number of Part B services furnished via telehealth. Some examples were office visits, kidney disease, education services, and telehealth consultations. Medicare beneficiaries were only eligible if the originating site was in a rural health professional shortage area located outside a metropolitan statistical area, or what they refer to as an MSA, are defined in a rural census tract. Well, in response to the COVID-19 pandemic, CMS moved swiftly to significantly expand payment for telehealth services and implement other flexibilities so that Medicare beneficiaries and certainly health plans embraced it as well, living in all areas of the country can get convenient and high quality care from the comfort of their home while avoiding unnecessary exposure to the virus. Before the public hearing PHE emergency was enacted, only 14,000 received a Medicare telehealth service in a week, while over 10.1 million beneficiaries have received a Medicare telehealth service during the public health emergency from mid-March through early July. So significant expansion, and I don't see that those will change, and I believe that they will be enacted permanently to allow for that coverage. So keynotes and takeaways that hopefully we were able to address during this component of it was understanding the common billing requirements, basic billing rules and payment methodologies for some of the more nuanced providers, and where we are with telehealth in the healthcare industry and where we think it's going to go. So polling question, which statement is not a unique billing rule specific to providers? Okay, Diane, let's close it and move on. Okay, yes, number 2. This statement refers to a common billing issue with hospital-based physicians that are not contracted with the hospital. Patient has no choice of physicians and may receive surprise bills. Okay, so read through that carefully. I know reading through that, there was a lot of questions throughout that. Yeah, I again pulled this directly from the e-learning course from HFMA. It will explain each and every one to you as to what it is and what it's not. So take the time to actually go in and read through those for you. Okay. All right, health plan contracts. Talk about the different health plan contracts and reimbursement methodology that's out there in the industry today. Lots of them. And then talk about what we call our silent PPOs, which anybody that is in revenue cycle and is seen today can be a major issue for reimbursement for providers to try to manage. So lots of different contracts. We'll go through these quickly. So as the healthcare industry transitions from volume to value, the variety of alternative payments is expanding, and the associated financial risk providers will need to manage is increasing as a result. Alternative payment models are expanding to include coordination of care and quality components. So the least risky payment system would be fee for service, where a provider is paid for each unit of service without constraint on spending. The highest risk is capitation, where providers share savings from better care coordination, but could also have very costly service that could erode any profit margins. So health plans are going to negotiate with various providers and contract based on discounted payment methodology. This can be as simple as a percentage discount to complex case rates with outliers. The difference between the provider charges and the health plan negotiated payment, excluding patient liabilities, is written off as a contractual allowance and may not be billed to the member if it's a contracted payer. So percentage off the cost of care is common. Perhaps I've got a 10% discount, but from a health plan's perspective, there is no incentive for the provider to control costs. Per diem literally means per day and do not vary based on the level of services. Typically used to pay an institutional provider where the level of care is relatively stable. DRGs, very common in inpatient, are a system of classing inpatients on a basis of diagnoses into clinical similar groups. The coding of all services and comorbidities impacts the DRG that a patient can be put into. Same thing with APCs. It divides all included outpatient services into nearly 600 procedural groups. The services within each group are clinically similar and require comparable resources, and each APC is assigned a relative payment weight. Fee schedules are typically used for CPT coding like radiology and laboratory, and will have a fixed fee payment based on a negotiated rate. You charge $100, they're going to pay you $75 for that CPT code. Case rates are fixed procedures for things like orthopedics, oncology, transplant services, and certain outpatient procedures where the utilization and cost is relatively predictable. Package or episodic pricing is very similar as well, where it's going to take procedures such as orthopedic procedures and sterilization, package it up to include globally all the services that will be included across a continuum of care, not particularly just related to a hospital. Bundled payments by Medicare is bundling that better care, including non-physician providers, in order to better coordinate patients' care. So things like the comprehensive joint replacement bundle make sure that all joint replacers have a bundled payment across the entire continuum of care. And capitation, which is also known as per member per month, is intended to pay the provider that's enrolled in that capitation a fixed monthly fee for every patient that's enrolled at that moment in time. And it is intended to motivate providers to provide preventative care that will avoid the patient having to have high costly treatment. But again, as we said, it's the most risky at this point in time because sometimes you can't control a treatment or a service. And so they could erode profit margins very easily based on certain conditions that their members may get. So this refers to a scheme where health plans do not offer PPO policies, but they apply the PPO discounted rate to patients' bills that are not part of that PPO negotiated rates. Basically, what these health plans do is they obtain the database of preferred provider rates from a PPO or from a middleman called a discount broker. These discounts are applied to claims, and the healthcare provider receives a discounted payment. As part of the PPO scheme, health plans try to pass off the discount as a legitimate contractual allowance on the EOB. Typically, the medical provider accepts the health plan payments on the EOB and writes it off, never knowing that the discount was invalid. Some providers do put in payment variance processes to find those, pursue the payment, or they contract with a company that does zero balance reviews to find those on a contingency basis. Providers are not required to accept those discounts, but usually the only recourse is to balance bill the patient, which is allowed, but typically results in patient complaints and non-payment. Patients are basically getting an EOB that says that's a contractual adjustment. You cannot bill me, and it is an invalid adjustment, unfortunately. So what can you do to identify these? I do know that we had on our insurance cards, I think it was multi-plan, if I remember it, there'd be a little logo. And our staff were trained to review those and let that patient know that we were a non-contracted provider service. We had them actually sign that. So when we did bill the patient, because we didn't apply the adjusted rate, we could refer back to that. Still didn't make them happy, still didn't make them pay, but we were looking for that logo that we knew was going to be problematic for us. In addition to that, examine all your contracts, determine if there's room in those contracts for health plans that do not offer PPO discounts. There may be language in there that basically kind of alludes to it. You can be aware of the following other red flags. Health plan is auto or workers' comp, not normally negotiated. The name of the PPO is not provided. Hospital has no PPO agreement with that payer or health plan or at all. The PPO discount is on the check, but not on the EOB. It's identified, but the contract was prior to claim processing. And then the EOB comes on a bill repricing letterhead. And then again, if the patient did not mention the PPO during pre-access processing, that should be a red flag. If the silent PPO continues to take illegal discounts, certainly a provider could choose to take legal action. And many times we'll see hospital associations and states work with their providers to fight those silent PPOs as well. So certainly get involved with your hospital association and your peers to see what they're doing with those as well and kind of getting back up on them. So key points, lots of ways to get reimbursed, which impacts your contract rates, which obviously impacts any estimates to your patient. So know what those are, make sure that your calculation rules and your allowed amounts are reflected appropriately based on those contracts. And then the importance of finding PPOs, again, it's a scheme to reduce your payment, that they are obligated to pay full payment if you're not negotiated with them. So looking at that, because that could typically be more of money than you probably think so. So those impacts of those and identifying those. So next polling question, thanks Diane. Which concept is not a contracted payment model? Not a contracted payment model. Okay, in the interest of time, let's get that closed out. Great job, guys. Percentage, capitation, and per diem payments are all contracted payment models. Stop loss provision is this common provision is found in health plan contracts that provide protection that medical expenses that exceed certain levels. It is important to know when those contracts include those provisions to ensure that the additional expected payment can be included when determining a patient's liability. These are most commonly seen when you're looking at self-insured plans where the employer is actually responsible for the actual cost of care. They may use a third party to do the administration and claims processing, but the cash is coming out of their actual amount, not the insurance company. And they put in stop loss provisions that after a certain amount, that stop loss comes into play. Okay. So I think we're kind of at the end. One more polling question, Diane. I think we have this one. There you go. Sorry, which payment model is also called per member per month? I think this one's a pretty easy one, so we'll close it pretty quickly. Yeah, capitation. I tried to say that a couple of times, so hopefully you got that. Again, capitation is your most risky payment model that you could possibly contract for. Could be very beneficial if you are really focusing on preventive care and you tend to have a pool of healthy patients, but can be very risky if you don't. Good job there, guys. All right. So now we'll open it up for questions. Anthony, any questions on the chat that came up while we were going over the slides?
Yes, if you could please briefly go over the value codes again.
The value codes are going to be your condition codes, your occurrence codes, your occurrence span codes, and the value codes. I think I got them all: occurrence code, occurrence span codes, condition codes, and value codes. Condition code is going to be something like employee related, right? So I need to let them know that this is an injury or illness that is related to condition of the treatment. Why am I being treated? So the condition, the occurrence code is associated with the condition codes. Again, employer related, but what was the date of the accident? Occurrence span codes is going to cover something like while a patient is an inpatient stay, perhaps the last 3 days of treatment are non-covered, right? Not medically necessary. If you remember the story of the family that I told on a previous one that refused to pick up mom because they were going to the beach, and her last 3 days of stay would have been considered non-covered because she did not require that level of care. We couldn't just throw her out. Nobody picked her up. So we'd have to put in those 3 non-covered days and the dates in question. And then the value code is monetary in nature as it applies. And that would be something like the most common value code 01 is going to be your most common semi-private room rate, which needs to be put on that. Now, I don't see hospitals charging for private room rates anymore or too often. It used to be much more common where you did it based on patient's convenient or request. Because you had semi-private room rates right now, most hospitals have moved to 1 patient in 1 room if they can. And then that still is considered a semi-private room rate, even if because they only have 1 room charges. They can't charge private room rates, they charge semi-private. Hopefully that asked the question. Anthony, any more?
Yes, I'm not sure what slide 70 is, but if you could go over that slide again.
Okay. I don't know what it is either. Okay, so silent PPOs. They are health plans that basically go out and obtain the database of preferred provider rates from an existing PPO that you have, or from a middleman called a discount broker. They are not contracted with you. They are not legally able to take that discount because they're not in your network. You should only take contracts on that people are take discounts on plans that you have contracts with. So they go out and they reprice it at a discounted rate. They should be paying 100%. They discount it at that rate, and providers aren't finding it, right? They just write it off because legitimately the EOB looks like it's a contractual allowance. So ways to try to find those and go after the silent PPO to get that money. You could bill your patient, but they're not going to be happy. Or again, take legal action, work with your hospital associations and your peers to go after those silent PPOs. So they're eroding your profits. They're taking money that they're not, allowances that they're not legally allowed to do. Okay. Anthony,
Okay,
other
great.
questions?
Yeah, so I know the presentation will be uploaded to the YouTube
Yep.
channel, but will the PowerPoint deck or a PDF of that also be posted to the website? That might be a Diane question.
They're being posted to the website, and the YouTube channel will have the video up as quickly as Diane and her team can get it up there.
Okay, and then the last one I'm seeing here is if you could just go over quickly the EB40 form versus the CMS 1500.
Yeah, that's simple. Your UBO 4 or 837I institutional is intended to go for institutional providers, hospital providers. Really, what it basically summarizes the treatment that under revenue codes, CPT codes, and then the CMS 1500 or 837P is more for professional claims, physician claims, home health, things like that, that are not considered institutional or hospital claims.
Okay. Any other questions?
Cool. Anthony, any updates you want to give to the group while we're giving it another minute or two on updated events coming up?
Sure. Actually, I'd love to let everyone know about another event we have today. As a matter of fact, at 2 p.m., we have our part 2 of our election coverage. We have an amazing panel of 3 national representatives and or 2 national representatives and a local representative here for Florida, discussing essentially the election and what now. So join us at 2 o'clock. Diane just put the CVent registration link in the chat, so feel free to register. It is free, and the more the merrier. Also, on December 10th, we have our next installment of our HFMA Fund Committee and Education session, our Happy Holidays Happy Hour. So that'll be 2 education sessions followed by a mixology happy hour that all can attend. So that link is also in the chat. Please register and join us.
Great. All right. Any more questions, Anthony?
Let's see. I don't see any.
Okay, great. Well, we'll end then. Certainly those of you probably know how to reach me if you have any questions. Again, encourage you to please go out, get into that e-learning section. There's a lot of material we cannot go over in the time that we have allowed. So try to get out there, read more about this, and then certainly send us questions as necessary. We will have 2 more actual sessions going over Unit 4 next week. Next week we have moved to Wednesday, I believe, versus Thursday. You should have gotten an updated one. Diane will make sure that that's out to everybody. Just due to some scheduling, trying to keep it consistent, but work unfortunately gets in the way. And so we'll be moving next week's session to Wednesday at 12 o'clock. And then our final session, and hopefully you'll all be ready to take the exam, we'll actually be going through and doing questions, some of the ones we've already done and some new ones to get the understanding of what questions might look. Again, I don't know if these are going to be the questions that are in the exam. And even if I did, I couldn't give them to you. But we'll go through materials and we'll create some questions that we can go over. So, okay. Thank you all for joining us, and I look forward to talking to y'all next week. Enjoy the rest of your week.